Hi, this is Dr. Imam with Cure Allergy Clinic. I'm going to be doing a review of all the inhalers that we use in asthma. Now, start off the bat, if you Google respiratory inhalers at a glance, you'll get this chart right here. Now, this is the 2017 version, but for our purposes, it should be more than enough. But you can get the most up-to-date version whenever you just Google this, and you'll find this chart, which is kind of supplied by the Allergy and Asthma Network, as well as the American College of Allergy, Asthma, and Immunology. Now you can see there's a lot of inhalers here, and in another video we reviewed how these inhalers actually work and why we have essentially so many. But we're going to do a quick review and then we're going to kind of break this down section by section until you understand all the inhalers. Now this review is good for anybody who's currently taking these inhalers, anybody who works in a respiratory field such as pulmonology or asthma and allergy, and any healthcare provider that's kind of interested in why we would use one inhaler over the other. Okay, so just as a quick review, we have here this circle is the bronchus, and this is the tube in which air enters. So normally we have kind of the windpipe, the trachea, and then it breaks off like this into the lungs. Now this breaks off into smaller and smaller pieces, and those smaller and smaller pieces eventually end up at the alveoli, which exchange happens of the gases. So in order to get the air here, we need the air to go through here first. And these airways need to remain open. If they start to close down, we start having decreased airflow and we'll start to have shortness of breath and wheezing. Normally, these will open up when we need them to open up, which is called bronchodilation, and they'll close down when we need them to close down, called bronchoconstriction. And this normally happens depending on what we're doing. So let's erase this really quick and get started over here. So let's go down for the first classes. So the first classes right here, we're just breaking down that chart. We call these the short-acting beta-2 agonist bronchodilators. We're going to call these SABA for short. What these do is on the bronchus, there is a beta receptor, and it opens up the airways. So if we activate it, it'll open up the airways, and that's how these work. So essentially, this, and this is all albuterol. So albuterol is a beta-2 agonist, and albuterol will open up these airways. These are short-acting. They will take effect in about 15 minutes, and they will last for about 4 to 6 hours before this starts to relax again over here. Now, why would you use one over the other? So essentially, this one, and this one, there's no difference. So these are all albuterol, and as you can see, it says albuterol sulfate, albuterol sulfate, albuterol sulfate. Also, notice that it has, let me just erase one, these all have the word HFA here. And this is a propellant that allows it to go. These are the inhalers that you kind of see in the movies where if we have the inhaler here, you press the button here and it'll spray out the albuterol. And a person has to time this well. They have to put this in their mouth, spray, and then suck in as hard as they can to get it to stick to their lungs. So it requires some coordination. Now, the RespiClick is different. The RespiClick here is a powder. So you don't have to coordinate. You just open it up. There's nothing to press. And once you open this down, there'll be a powder inside ready to go. And you just put your mouth on this powder and you suck it in as hard as you can. And that's how you'll get your dose of albuterol. This is good in the sense that you don't have to coordinate it. You just have to put it on your mouth and suck it as hard as you can. While this one, you have to spray it and you have to coordinate it. If you spray it and then you wait 10 seconds, then you suck in, it'll just stick to the inside of your mouth and you won't get it into your lungs. If you spray it too late, you won't get it into your lungs. You have to spray it just right at the initiation of the breath. Okay? So we're going to erase all this to get to the last one. The last one here is Xopenex, HFA. This is not exactly albuterol, but this is levoalbuterol. Now, just to go into a little detail here, albuterol has two enantiomers that you inhale. An enantiomer is kind of like a mirror image chemical structure. We have an S and an R. Now, the S is what causes our effects of bronchodilation, and the other one doesn't really help. Now, essentially, when you inhale it, you might get some side effects from these. These might feel like your first cup of coffee or first cup of espresso. You might get a little bit of tremors. You might for about a couple of seconds, and some people get a little bit of an elevated heart rate. So people who can't tolerate these inhalers because of elevated heart rate, usually people who are older might have a history of atrial fibrillation, they can use Xopenex instead because this is just the version of the albuterol that does not cause the tremors. But this is usually not covered by insurance companies and pretty expensive. So usually this is the first line. And then if someone doesn't tolerate it, they can use these. These are all useful as needed. So these are the ones that you will always see, say, Q every 4 to 6 hours, PRN, which means as needed for cough, wheezing, or shortness of breath. Okay. The next set of inhalers over here are the long-acting bronchodilators, which we call here the LABAs. What these do is these activate the beta receptor just like the ones above, but they last much longer. They're slower on and they're slower off, and these are usually used twice a day. Now, as you can see, these just happen to be powders. We almost never use these in isolation. Never, ever, ever. They're always used in a combination. These don't work that well on their own, so they need to be combined with a steroid, which we're going to cover next, or a LAMA, which we'll cover as well. So just notice that these are powders. So they all work the same way. You would put your mouth on them and inhale them. There's nothing to press to activate. There's no propellant in them. This one is a Respimat, which is kind of like, it'll look like this. You kind of twist it and then it'll spray it out. Now, different than that one, this one will be like like a mist will come out, while this one will be like a quick spray like you get out of a spray bottle. Okay, so the next class is the inhaled corticosteroids, which we call ICS for short. Now, what these do is that this is the airway. Not only will it constrict, which we're going to get rid of with the above inhalers, but it'll also get inflamed, and that will also narrow the airway because there's less room for air to move in. The inhaled corticosteroid will treat that by decreasing the inflammation. So, and there's several different types. Now, they all are kind of similar. You'll see some that say HFA on them, which means that you have to press them and coordinate them. You'll see some that are a powder, and that you can just put your mouth in and suck them in hard. Some that come as a disc, these are usually a powder as well. And that's kind of essentially the majority of them. Now let's go into them into a little bit more detail, why you would use one over the other. Now, a lot of the times, it doesn't matter which one you would use. Sometimes it's just because of insurances that you would use one. So we have Aerospan here, which is a typical inhaler. It kind of comes as HFA, really not a very popular one. Alvesco, similar, HFA, be just like the albuterol, also not that popular. Annuity is a newer one. This one is more popular because this one is once a day. The rest of these are all twice a day, but this is the only one that's once a day. And that just happens because it's a fluticasone furanate, which is different than the fluticasone propionate, and it lasts for longer. It sticks into the membranes and lasts for longer. This is a powder, just one puff once a day. Asthma is a popular one, and this comes in at HFA, so it'll be just like albuterol. Asthma, the twist inhaler, the Asthma twist inhaler is a powder. You just open this up, you twist it, and then you suck it in. This one's less popular because it is a little bit more complicated to use. Flovent is popular. Flovent is used in 2 versions, so depending on how you want to use it. So if I had someone who was like 4 years old, I would probably use this one with a spacer. But if I had someone who was older, had arthritis, couldn't time the movements, then I would use this one as a powder because they don't have to time it. Pulmicort is one of the safer ones during pregnancy, but also it has a complicated mechanism. And then QVAR is good because it activates the smaller airways. So sometimes you'll see somebody already on maximum inhalers. If their asthma is not controlled, they'll add QVAR as well. And it comes as an HFA as well. Then we have the combination inhalers. So these combination inhalers are a LABA ICS combination. Now, you have to use the LABA twice a day. And it's a maintenance medication. You can't use it as needed. So this is twice a day. And you have to use the ICS once a day if you're using annuity, but otherwise you have to use it twice a day. Okay? Now, these, because you have to use this one twice a day and it's a maintenance, and you have to use this one twice a day, you might as well put them in the same inhaler and just have a combination. And that's why the combinations are very popular. So normally in asthma, what will happen is a person will start with a SABA. If not controlled, then they'll start with an ICS. If not controlled, then they'll do an ICS LABA combination, which are these, and these are kind of well known. And these are all maintenance medications, so they don't work kind of on demand. You have to use them frequently and as a maintenance. So you have to use them twice a day frequently. Okay, so we're going to cut these in half because these are all on this side ICS LABA combinations, and on this side these are actually LAMAs, which we're going to talk about. next. So let's start with the ICS-LABA combinations. Okay, so we have the Advair discus, which is very popular. Everybody kind of knows about Advair. So we have Advair. Now this one is a fluticasone propionate and salmeterol combination. So a LABA ends with OL. All of the beta agonists ends with OL, and then the steroids usually end with SONE. So this is a combination. It's going to be used twice a day, and it's a disc. So you have to open it up, prop the disc, and then suck it in as hard as you can. Advair can also come as an HFA. This is not as popular, but this is one that you can one that you suck in just like you would with the albuterol Pro Air. These, if you want to use a spacer, you can use a spacer with them, and that's partly why you might use these as well. Now, your doctor will recommend one over another, but this is kind of why they all look different. Brio is a combination, and it's the only one that's once a day, meaning that one puff once a day of Brio will be sufficient, as opposed to all of these other ones you have to use them twice a day, morning and night. Dulera is popular, and then Symbicort. Now, the ones that kind of stick out here are Advair's the cheapest, so that's why Advair's popular. Brio's popular because it's once a day. Symbicort is popular because it's the fastest acting. So of all the ones we said they don't really work on demand, Symbicort is the quickest one to work. So someone's having an asthma flare, they can use the albuterol, but then they can also use their Symbicort, and that kind of gets them under control a little bit quicker throughout the day. Now, these here are LAMA, LABA combinations. Now, remember, I have another video that explains how these all work, but essentially, when we have the airway, the beta receptors open up the airway, and we want to activate them. But then we also have muscarinic receptors, which decrease the airway, so we want to inhibit them. And that's what these do. The LAMA inhibits, and then the LABA activates. So Anoro is a LABA combination, and this is once a day. The rest of these are all twice a day. The most popular of the two of them is Anoro and Bisvespi. These are usually first line in COPD. They're rarely used in asthma. Then we have the isolated LAMAs. So this is just like the ones above, but these are the isolated ones. So you have this is a short acting one, that's not very popular. So we don't really use this one often. The ones we do use often are most likely Spiriva. That one's because it's cheaper, and we use Incrus often as well. Now in COPD, these are first line. These or the LABA-LAMA combination. But in asthma, they're end of the line. So a good way of remembering that is if we kind of draw everything like this. We have we have ICS, LABA, LAMA. In COPD, it goes this way. In asthma, it goes that way. Meaning you go ICS, and then LABA, and then LAMA. In COPD, you go LAMA, and then LABA, and then ICS. And that's essentially it. That's a review of pretty much all the inhalers. So now when you see one, if someone says, okay, well, we're going to add Spiriva, you know, oh, they're adding a LABA or a LAMA. And someone says, oh, we're going to add Dulera. And then this chart's all there. So now this chart should make sense to you. And that's a really, really easy review for everyone. Okay, hope that helped.